Okay, I think that we will go ahead and get started. Well, again, I'd like to welcome everyone after our holiday uh, little weekend that we had there. Hopefully everybody had a safe and wonderful holiday. I'd like to welcome you to our final event for the year in our Race and Inequity Seminar Series. Over the last several months, we've actually looked at a lot of different groups for which equity has been lacking in the healthcare. Today, we are going to look at our veterans population, and I am so proud to have one of our own faculty and alum, Dr. Evelyn Lewis, speak to this group. Dr. Lewis earned her medical degree from Chicago Medical School, and she did her family medicine residency at the Naval Hospital in Jacksonville, Florida, a 2-year faculty development fellowship at Madigan Army Medical Center and Pacific Lutheran University. She has a master's degree in social and behavioral sciences in June of 2003, and she's now retired after 25 years of giving service to our community with the Veterans Administration. I had the opportunity to work with her on the Commission to End Health Disparities and also as an AMA delegate there. She is nationally recognized for expertise in community outreach and engagement, cultural competency, and healthcare disparities, and has held several leadership roles in the uniformed services. She was also addressed in one of our classes of 2019 as Speaker of the White Coat Ceremony, and I'm sure that she will live up to her reputation in interaction with us today. You'll see her full bio again in the flyer that went out, but today she's going to be speaking on health inequities in the ranks, the impact of healthcare disparities on those serving our country. Again, I welcome Dr. Evelyn Lewis to Chicago Medical School today. Dr. Lewis.
Thank you very much for that introduction. And it's always a pleasure to be invited to participate in the education and training that I also thought it was that this is sort of the last presentation that you all will have during this month on some of these issues, in particular since November has been designated as Veterans and Military Family Month. So on the last day, we will actually get to talk about some of these issues that impact veterans who have served our country. And for some reason, we're not, the slides are not moving. So we may have to revert to our end of round. Can we do that?
Hey, Dr. Lewis, I see we're having a technical issue.
Yes.
So can you tell me, are you just like clicking the arrow and it's not going forward?
Yes.
Maybe since we have a copy, can we go ahead? Maybe Christina, do you have it? And Dr. Lewis can just let you know when to.
Yep, we can definitely do it that way.
Okay.
I also want to remind people that there's a chat box, and we have 2 students who will be doing the questions as we usually have tonight, and they will certainly introduce themselves later. But please put any questions that you might have in the designated sections, and we'll let you make sure you know about that as well. The other interesting little facto about my friend Dr. Lewis is that she makes these great pies. She could do that probably all on her own besides medicine, of which she excels in as well. So I think we're ready to go, Dr. Lewis.
Thank you. Next slide. Okay, so in regard to the objectives, we're going to start by describing the difference between some very basic terms, because what I've come to learn or know is that many people use these terms interchangeably, and they really do have different meanings. So we'll talk a little bit about health equity, health equality, health disparity, and healthcare disparities. And then we'll move into identifying members of the veteran community and why that's important, and how we use that to justify potential need for early or additional screening and testing. Next slide. So describing the difference between the terms that I previously mentioned. Next slide. So when we think about health equity, it's sort of social justice term, if you will. If you think about it in that way, it's a little bit easier to differentiate from the others. And it means that everyone has a fair and just opportunity to be healthy. It requires obstacles to reaching that health status, such as poverty, homelessness, other kinds of financial instability, all of those kinds of things that make people vulnerable to accessing good health. So that's where health equity comes into play there, and why it's looked at as a social justice term. Next slide. Health equality, this simply means that everyone has the same and equal opportunity to be healthy. An example that is used is that you could include a community community health center offering free and low cost checkups. And as long as every single element that is offered is the same thing offered to those people, then we're talking about health equality. Next slide. Health disparity, again, this refers to a higher burden of illness, and you'll see how this comes into play as we talk about people of color and other sort of sub populations where they have injuries or disabilities or mortality that is experienced more by one group relative to another. A difference that affects a person's ability to achieve their best health, and that sort of, if you will, gets back into that health equity definition. And then examples of health disparities include things like race and gender, education, income, disability, sexual orientation. Those kinds of issues feed into health disparities. Next slide. Healthcare disparities, on the other hand, typically refers to differences between groups in health insurance coverage. In other words, their ability to access quality healthcare, because we know that different abilities exist to access care, but it's always access to what kind of care. So we stress the word quality. And again, we'll talk a little bit more about that also. Next slide. So identifying members of the veteran community. Next slide. What does that mean, and why would we need to do that? Why is that important? It's important because, as you can see from this slide, if we estimate that there are about 20 million or so veterans that are a part of our population. 6 million of them are treated on a basis. That doesn't mean that they get all of their care there. It just means that 6 million of the 20 get some care at the VA. So if I back that up a little bit, I'll give you another number. So there's 20 million veterans. There are 9 million who are registered with the VA. And of those who are registered, 6 billion get some type of care there. And less than 3 million get all of their care from the VA. Why is that important? It's important because if only 6 million are getting some of their care there, then the rest must be getting care somewhere else. And that somewhere else is in your clinic, it's in your office, it's in your medical school. So that's where they are. And that's why being able to identify them is very, very important. Next slide. So what are some of the attributes? And these attributes are not the best, but they're the ones that we're going to talk about tonight because they really point to the reason why, again, it's critically important that you be able to identify who they are. So we talk about chronic illness, and you'll see where that plays a key role in the veteran community. The vulnerability. Veterans are now described or classified as a vulnerable population. Diversity in race and ethnicity, gender, age, sexual orientation. All of those elements of diversity also are attributes of the veteran community. And when we look at expanse, you heard me mention a few minutes ago that there are about 20 million vets. Well, when you include their family members, they make up about a quarter of the population. So 1 in 4 people that you see in your clinics, your hospitals, your medical school clinics are either a veteran themselves or has a direct connection to a spouse, partner, child, mother, father, etc. Next slide. Veteran statistics. So this is a snapshot of what a veteran community may look like. And again, you heard me mention there are about 20 million veterans or so. And so depending on whose numbers you use, you'll get 18 to 20 million veterans who are out in the US population right now. About 91% of them are male. Female veterans, when you look at them as a subpopulation of the veteran community, they are definitely more racially and ethnically diverse than their male counterparts. About 23% are minorities, which is predicted to increase to 33% or so by 2037. Now, that's a very important block, particularly as we move through our conversation tonight. And you hear some other things around the issue of disparities and equity and health disparities, et cetera. Just remember that right now, about a quarter of the veterans are minorities, and that's predicted to increase over the next few years. Over 7 million are from the Gulf War era, and about 6.5 million are from the Vietnam era. And it was up to probably 2 years ago where the Gulf War era veterans eclipsed, if you will, the number of Vietnam veterans. So that is now the highest number of veterans that we have are from the global war on terror era. You have about 4 million vets who have service-connected disability. That will also become another important term as we move through our conversation tonight, what that means. And you'll see how that also intersects with the issue, if you will, of minority veterans. You have about 11% who are homeless, 45% are African-American, or Latino, or Latinx. About 40% of veterans, about 40,000 veterans are homeless each night. So that number of total homeless veterans may vary, but about 40,000 or so are homeless every night of the year. And then we talk about suicide risk. It is 22% higher for veterans, and about 20 a day commit suicide. Next slide. So in terms of identifying veterans who come into your clinics or your hospitals, this is an assessment tool that was developed by a nurse practitioner and colleague and friend of mine in New York. And this is just what the acronym stands for. It's a lot more detailed than this, but I wanted to just show this to you and share with you how you can get additional information, more in-depth information when you have a veteran. The V standing for veteran is expertise or occupation, which is again very important. Time in the military, years of deployment, environmental exposures, which is another key element. It also helps you better define what era they fought in, i.e. if you were to think of Vietnam, most people, if I ask them, what do they associate Vietnam with? They mention Agent Orange. And then I will say that each of our conflicts has its own Agent Orange. Because you have that for Vietnam, you have depleted uranium for Gulf One, for Gulf Two of Iraq and Afghanistan. You've got burn pits, which you'll be hearing a lot about in terms of some of the injuries and illnesses that are currently being investigated to see whether or not they're definitely associated with these illnesses. You have near-death experiences or diseases, stress, anxiety, because as you talk about a veteran, you must always remember that it's not in isolation, that they are affiliated and are associated with some other people somewhere. And so their illness and injuries and diseases impact those members, whether they're direct family members, blood family members, if you will, or others who just care for them. They impact their health also. Next slide. So when we talk about commercial healthcare, I'm simply talking about outside of the DoD or the VA healthcare systems. And many can be unaware, and if they're unaware, may not be necessarily trained or prepared to care for veterans. And again, this is important because you heard me say early on that there are about 20 million out there, 9 million are registered with the VA, but only about 6 million get some of their care there. So they're out in the commercial health. And if you're aware of that, then you may not be trained or prepared to identify the kinds of things that you need to early on that impact their health and their healthcare outcomes. So the RAND Corporation did a study about this regarding civilian healthcare providers, physicians, and others in terms of their readiness to care for the veteran population. And they found that only 2.3% of all healthcare providers met the criteria that they used, which we'll talk about in a minute, for readiness to deliver timely, culturally competent, high quality care to veterans. Next slide. So as you can see here, it was New York State. They were researching their capacity of licensed healthcare providers, which included physicians, PAs, NPs, mental health care providers, workers, health counselors, the whole gamut, if you will. And then if we looked at, again, ready or not, assessing the capacity of New York State healthcare providers to meet the needs of veterans. So they had this list of elements. And if you started with that providers or that system's ability to accept new patients, that's sort of where they started. And once they started there, you can see that 92% of those healthcare providers or healthcare systems had the capacity to accept new patients, those new patients being veterans or others. If you went to step 2 and you looked at if they could accept new patients, were they prepared to treat conditions that were common among veterans? You see it went from 92% to 59%. And so these are cumulative. So if you can accept new patients and you're prepared to treat common issues in veterans, do you use clinical practice? You see it drops again to 42%. If you add on screening for conditions common to veterans, it's 25%. Accommodates patients with disabilities, 17%. Familiar with military culture, 5%. Screens patient for military veteran affiliation, 2.3%. You can't do very much for their medical illnesses, injuries, and diseases if you do not know who they are. Next slide. So looking at what would it take, or what are the things that we look for that justify a potential need for early or additional screening or testing for someone who presents as a veteran in your clinic. Next slide. So if we think about comorbidity and how and where that plays an important role in this patient population. So when you era, i.e. WW2, Vietnam, Global War on Terror era, you can see the number of chronic conditions increases. So in World War II, the average warrior had about 2 chronic conditions. Vietnam, it was 4. Global War on Terror, 8 to 9. And if you take the Global War on Terror for someone who had multiple deployments, that number goes to 11 to 12 comorbid chronic conditions. Next slide. And if you look at these chronic illnesses, you can see that many of them are obviously very debilitating when we talk about environmental stress and the toxins or the environmental exposures, combat itself. And when we talk about no OSHA protection, the air that our veterans, warriors breathe day in and day out. Back in Afghanistan with the burning of those pits where they dispose of waste, human waste, dogs, automobile parts. They would light those fires using jet fuel. So you can imagine all of the toxins that were emitted that they breathe in every day, all day long. So these kinds of conditions come together and transform some of the healthiest of the healthy into the most chronically ill. And we can show that because we know you have to meet certain conditions to be able to get into the military to serve. And then when you look at what comes out on the other end, it's very, very different from the person who went in. Multiple deployments, again, play another key role. You have increased the numbers of survivors in chronic conditions and comorbidities, again, increase. So why is this important? I was presenting to a group of docs and nurses at one of the hospitals some time ago, and I was talking about young military men and women who are out there, they're, fighting the battle and defending our freedom. And I was talking about the importance of understanding who they are, and why it's important to be able to connect those dots, if you will, because they're young, and there are a number of things that play into that. And one of the nurses said to me, well, what's so different? We always send those who are young to war. I mean, basically they're 18, 19, 20-year-olds who we send out there. I said, yes, you're correct. And that's still the case today. The issue that's different is they're at home. Many years ago, if you were to look at World War I and II, and even Vietnam, the injuries and illnesses that we see 20, 25-year-olds, 30-year-olds with now, they typically would have died on the battlefield with. So we can bring them home. We can keep someone alive and able to talk and what have you, and understand, and they have absolutely no limbs at all, no arms, no legs. We can bring them back and they can have no face, no facial features, because they walked into some explosive area and their facial features were destroyed. So we can bring people home now who died on the battlefield before. And because of that, we need a better and much deeper understanding of how to provide their care. And don't forget about the families, because they are not spared. They become unhealthy relative to their non-veteran family counterparts because of what they have to do with that spouse, partner, child, mother, father who comes back, because nobody who goes there comes back the same person. Next slide. So this speaks a little bit to chronic illnesses. And you can see here, it says 79% of veterans reported at least one chronic medical condition, 82% in deployed versus 78% in non-deployed. And the reason I put this slide here, the important piece is that most providers, most folks in the healthcare system would think that we're only talking about those people who get deployed, who leave their components, or in the United States, as we say, bases or posts, and travel someplace else, like to an Afghanistan, Iraq, or Vietnam. But that's not necessarily true. If you look at Gulf War illness, about 20% of those who were not deployed also had some of those symptoms. You look at hypertension, COPD, migraine headaches, all of these things, which are some of the most common illnesses, if you will, occur both in those who've been deployed and those who weren't. So again, you need to still pay close attention, even if you were to ask that person if they were a veteran, had they served, and you begin to talk about their deployments. Don't necessarily exclude things because they were not deployed to another country. Next slide. So some of the top injuries will potentially see that we now know about 1 in 10 veterans may experience any one or combination of these things. And one at the top of the list is the Iraq and Afghanistan war lung injury. And again, as I often talk about this, one of the examples I will use is that if you were in the height of allergy season and someone came in and they were short of breath with exertion, cough, they might have been a smoker, may not have been a smoker. but just this respiratory issue is impinging on their ability to live their life as they once did. And so if we were to go down our list of differential diagnosis, if you did not know that this person served in Iraq and Afghanistan and was a veteran, you would not even come close to considering Iraq, Afghanistan war lung injury. So again, that's the importance of knowing that someone has served. Okay, and what were the things that they could have potentially been exposed to cause or be associated with the problem they're presenting with. Other things include dyspneic complex blast injuries. Again, one does not have to be right in the vicinity of an explosion. You can be some 500 feet or so away, and the shock waves can still cause significant internal organ damage. Post-traumatic osteoarthritis. All of us know about PTSD, but very few people know about or talk about PTOA. And if you were to look at what was the highest ranking injury or disease or illness that that was rated for anyone who served in the military, it's not PTSD, it's not TBI, it's not even another mental health disorder. It is a musculoskeletal injuries, and they include things like osteoarthritis. Chronic multi-symptom illness is another name for what used to be called Gulf War syndrome. When they named it CMI, it was because they put some criteria around it, i.e. having to have X number of symptoms for X number of months to be classified as potentially having chronic multi-symptom illness. Genitourinary trauma, we know a lot about that in terms of if you're a point man or if you're on the ground and you're walking, the roadside bombs explode. And that's where we've gotten lots of injuries with genitourinary system in the lower limbs. Sleep disorders, other things like chronic issues that we always think about: diabetes, cardiovascular disease, cancer. Pulmonary arterial hypertension is another big, which if you aren't looking for it and you don't recognize some of the things that lead to that, you would not be suspecting that in someone who is served, particularly if they're younger than when you typically see something like that. Kidney disease, immune disorders, etc. Next slide. Next slide. Mental and behavioral health conditions. I separated these out because they fell under that title. A lot of us, again, talk about post-traumatic stress disorder. You went one slide too far, but we'll talk about PTSD, traumatic brain injury, anxiety, and depression are probably the four most common kinds of mental and behavioral health conditions. Sometimes we talk and include depression, significant depression, as a part of mental and behavioral health concerns. When we look at traumatic brain injury, blast-induced TBI is sort of the signature injury, if you will, of Iraq and Afghanistan conflicts. This was predicted at the beginning of this conflict when our government again asked the RAND Corporation to research what the potential injuries and illnesses would be that our warriors would face in that battle area and what they would be returning with. And so the RAND Corporation listed TBI as lead or signature injury of the Iraq-Afghanistan conflict, and we have come to realize and recognize that to be true. We know that that's an alteration of brain function because you could get TBI from a number of different things, but when we're talking about those in the military, much of it comes from blast injuries and what have you, and it interferes with thinking, language and understanding, emotions. Sometimes it causes a lot of aggression, acting out, anger. They have issues with expressing themselves and understanding and communicating, and memory and reasoning. TBI can also cause epilepsy or be associated with epilepsy and can increase the risk for such diseases as Alzheimer's and Parkinson's. Next slide. So again, we have some connections here, which we call a vicious cycle. This was a diagram that was developed by a colleague and who's a psychiatrist. You can see at the middle, there's unmet mental health needs, which we see a lot of in the veteran population. And we can see that those arrows emanate out from that center and intersect with these 4 other squares, one of which is violence and incarceration. We see a lot of that from veterans who are having issues outside, particularly if they're homeless or unemployed. And you can see that's one of the squares where unmet mental health needs leads to. Poor physical health, the diabetes, the cardiovascular disease, cancers, all of those kinds of things that we talked about before also. And then again, substance misuse is another huge element of unmet mental health needs. And so if we started at the core there, we could, again, impact a number of different health and healthcare issues that the face. Next slide. So crisis within a crisis, as we think about where we are with COVID-19, and we think about the warrior community or the veteran community that we've just talked about, when you think about all of the things that overlay the conditions that veterans face in terms of higher risk of hypertension, diabetes, cardiovascular disease, all of the environmental exposures and toxins that can heighten their risk for other things, like we just talked about, increased risk for Alzheimer's and Parkinson's, et cetera. And if you think about the population that COVID-19 impacts heavily, they are those people who are older, those folks who are because of obesity or comorbid or chronic medical conditions. So you can see where being a veteran adds an extra layer of risk, if you will, for COVID-19 and other sustained comorbidities that are associated there. So the question becomes, how do we then optimize their care? Next slide. So we think about potential benefits, collecting using military and veteran status data to help us do these things. So if we go to the next slide, we'll look at each of those areas that we mentioned there. So analytics and insights. So again, having some way of labeling or identifying your patient as a veteran. It may be a flag that comes up, an icon on their EMR. Again, they mentioned a flag here that could appear on the veteran's record, so that providers know there's a cue there that, oh, this is a veteran here in my office. I need to ask some additional questions. I need to perhaps do some additional testing or screening earlier than I might do on another patient this age with this problem. Next slide. As we think about education and training, kind of what we're doing now is learning some different information about patients who are among the veteran population. So asking more detailed questions, follow-up questions about their status, military affiliation, whether or not they were deployed, socio-demographic questions specific to military experiences, and in particular, exposures. Again, are you currently in the military? Do you have you ever served in the military in the past? Asking about spouses or partners who've been members of the military, et cetera. Next slide. Again, education and training look at providing staff with clinical education on the cultural and environmental exposures unique to military service. Again, when we talk about cultural competency, one of the things we have to recognize is that it doesn't just mean the actual person, i.e. the doctor, the nurse, the social worker, et cetera. Everything about that experience needs to be culturally appropriate. And so there are some things that you would need to do to get to that point. And once that happens, then obviously it becomes a lot easier to interact with and have a very good patient provider encounter when you're dealing with the veteran population. Next slide. Analytics and insights. Analyzing member patient data to identify health and healthcare disparities among the veteran population that we're talking about. So knowing and understanding the demographics of veteran communities and what their health determinants are and what they indicate. Next slide. So this is the question slide. And if I had been able to do the deck from my end, I had added 2 additional slides. And so I'll just talk to them before we do questions here very quickly. They were 2 slides from an article that was written by Shinseki, who was the head of the VA, probably I think about 2 or 3 people ago now. But anyway, it talked about healthcare disparities in the military population, in particular African Americans. And the way in which it was spoken about lends itself to this issue that a lot of people hear me talk about a lot of times, where I talk about intersectionality and how things come together, and so that we don't look at things in silos. And so as we think about, the injuries, the exposures, and all of those kinds of things that we talked about that veterans have more of than their non-veteran counterparts. Well, some of that is not necessarily just happenstance. It's not necessarily because you're African American, but it is because you're African American. And what I mean is, Shinseki did a great piece within his article where he talked about the numbers of African Americans who go, particularly in the enlisted ranks, and whether or not the percentages in terms of how they presented in leadership roles when they were mapped against all others. So you had African Americans, you had other people of color, and you had whites. And so when you looked at any of those numbers, there were always more African Americans, but less of them proportionately were in leadership roles. And if they were not in leadership roles, they were doing the kinds of jobs that would result in the kinds of injuries, illnesses, and diseases that would impact their health much longer down the road than those who were in leadership positions or had better jobs while in the military. And that becomes important when you look at what we call service-connected disability. What that means is that you had some kind of injury, illness, or disease that you got while you were in the military, or that the military aggravated and made worse. And so when you come out, you're discharged or retired with what's called a service-connected disability. The VA has a very interesting way of adding that up. So if you've got 10% disability for an ankle injury and 20% disability because you broke your arm and you have some pain, et cetera, from that, that's not 40%. It might only be 10%. So there's a different mathematical process they use to determine service-connected disability, and it can go from 0% all the way up to 100. Because African Americans have the types of jobs that we talked about earlier, while they are less in the leadership positions, with higher percentages of service-connected disabilities than any of the other subpopulations within the military. So again, when you see these folks in your offices, it is really extremely important to ask the question, are you a veteran, have you served? And then begin to ask additional questions so that you can find out if there's a service-connected disability and if that service-connected disability has anything to do with why they're presenting in your office as a patient right now. So again, there's a lot more around that, but I just sort of wanted to mention that such that you could understand all of those other pieces that connect to this issue of having veterans in your rank, i.e. in your office, in your patient populations, and the importance of understanding why. Thank you.
Thank you so much, Dr. Lewis, for really enlightening us on the veteran, the impact really, and the inequities that exist and what we can do about it. I always like when we can have solutions to things. I'm going to turn it over to our students, student leaders that we have, Simone and Ken, and I'm going to let them go ahead and figure out the question and answers portion. Go ahead.
Hello, my name is Kenneth Ferd. I'm a fourth-year medical student from CMS, and I'm getting ready for residency. So our first question in Q&A is from Justin. Are there any disparities between veterans who were enlisted versus those who were commissioned during their service?
Yes, that gets to a little bit about what I was just talking about. So those who are in the enlisted ranks have some of the more physical, if you will, jobs and responsibilities than those who are officers. Officers or commissioned officers are looked at those who provide the leadership for the troops. And so obviously you want to cushion them, if you will, from injuries, illnesses, and diseases so that they can provide that leadership that's so desperately needed in certain situations. But if you are enlisted, there are several, step jobs, and they have all kinds of names and descriptions for them. And if you are relegated towards those types of positions, then you have increased risk of having some of the things that we've talked about. And as I mentioned, Shinsheki showed and described in his article that African Americans are more likely to have those kinds of jobs and positions, which then increases their risk of the things that we've discussed.
I'm Simone. I'm a third-year medical student. I'm also one of the Q&A panelists people. And just a reminder for your questions, ideally if you could put them in the Q&A box, but if you put in the chat, Kenneth and I are keeping an eye on both of them. Or if you want to ask a question verbally, you can press the raise hand function as well. But we'll keep an eye on everything. Dr. Lewis, I actually had a question myself. When we talk about how as physicians, we kind of need to be better trained to be able to take care of veterans because they do have specific needs. And I think it's one of those things that it probably, it should go as far as being put into our medical education. Nowadays we're looking at trying to incorporate more LGBTQ plus care in our curriculum. Same thing with trying to be able to treat different races and religions and kind of that kind of thing. So do you have any ideas of how, like, different ways that we can maybe try to incorporate taking care of vets into our medical education?
Well, one of the things I typically say is that if you can take care of veterans, you can take care of anyone. Veterans are merely a cross-section of our entire population. All of the subpopulations that you mentioned serve in the military. LGBTQ+, all types of religions, all ethnicities, males, females, old, young. They cross all of the sections there. So if we could take care of a subpopulation of people who have all of the components of the general population and some unique healthcare needs, then we should be able to address any of those others that are out in the general population who haven't served. So that's typically how I approach that, because if you're going to learn about special needs of LGBTQ, there couldn't be any more need than understanding that in somebody who wears a uniform. So again, if you could care for those who are in uniform or who have worn a uniform with those who fit those subclassifications or subpopulations, then I think that's a course that would teach us how to work with any patient that we had.
Thank you. Dr. Olivier actually put in a follow-up question. I think it was actually directed to me and not instead of the whole group. But the question is there something we can do to train faculty so that they can train others?
Sure. I do that. That's one of the things that I programmatically do is come in and do a half-day. So we get them to begin to understand the issues that we've talked about here tonight, sort of very compactly, but spreading that out, talking about many of the subcomponents of the illnesses, injuries, and illnesses that they face, why it's important, expanding on those kinds of things that we didn't touch on tonight because of time, and then looking at how they then carry that through longitudinally in terms of their education of students, because for them to learn and get educated and know and understand doesn't do very much if they don't then integrate it and follow up with it in their classwork or in their clinical engagement with students throughout the 4 years there at CMS. So yes, there are ways of doing that in regard to working with medical schools to integrate that piece. And it's a longitudinal piece, just like it should be with anything else we're learning.
I have another question. So I'm really interested in musculoskeletal care. And about several years ago, there was an article that was published and they compared the usage rates between of total hip and knee replacements between Blacks, whites, and also Hispanic patients. And they found out that there were very similar usage rates between Hispanic and white patients, but there was definitely a large decrease with Black patients to pursue hip and knee replacements. So my question was, and they found out that this was due to overall perception of the benefit of hip and knee replacement, so which also relates to health literacy. So what are your thoughts on, the whole idea of cultural competencies and how just a perception of certain healthcare services being understood by some, but not all of sort of veterans at this current time?
Well, again, a lot of that is incumbent on us to educate our patients in terms of those things that are misconstrued or misconceptions that they may have. When you look at the situation in regard to the veteran population, it's interesting because one of the things you will see, you heard me talk about PTOA, one of the things you will see is that you'll have knee replacements and joint replacements and all those kinds of things at much earlier ages in those who are veterans versus their non-veteran counterparts, because you get such additional wear and tear on the joints, jumping off the back of trucks and out of airplanes and out of helicopters and, trekking down roads for hours with 100 pounds on your back. So you are wearing those joints down much quicker than your non-veteran counterpart. So in doing so, it really becomes imperative upon us to ensure that those patients understand that when they get to that point, or as they're nearing that point, shall I say, that we are preparing them such that they understand why that need might occur and why it may occur for them and it would someone else. Because we're susceptible to getting bone-on-bone osteoarthritis issues maybe 5-10 years before your counterpart was, depending on how much jumping in and out of airplanes and trucks you did when you were in the military. So, that falls to us again about ensuring that we educate our patients in terms of what those kinds of environments and the injuries that they impose on us.
And my follow-up question is, with regards to the mental health and also the physical health concerns that veterans deal with on a day-to-day basis, do you think there is a call for this interprofessionalism to be more advocated for within the veteran healthcare space?
I do. Although we look at mental health as an issue, as a healthcare issue, and we know and understand that it is not where it needs to be anywhere. whether we're talking general population or veteran population. We're just not there. We're not doing enough to ensure that we are taking care of people who have those needs. And so when you, again, look at those who have served and some of the things that they have seen and done, they need that kind of intervention even more so than someone in the general population. One of the things that we didn't talk about tonight was moral injury. When you're in an environment like in Iraq and Afghanistan, I can remember one of the video clips I used to use some time ago, where there's a young guy in a tank, and he's driving down the streets of Iraq and, looking at the people, and he's saying to himself, I'm great that, I got all these machines, this tank, all these big guns, I'm fine, I'm safe. And he says, they're the children, and we play with them, we and then we have to kill them. So what do you think that does to someone? Because over there, when a kid starts to approach you, you don't know whether that child is coming to play or coming to kill you. So again, the issues that they face causes additional mental and behavioral health issues and concerns. And so they definitely need those kinds of interventions sooner and perhaps more intensely than some others might. And we are failing them by leaps and bounds.
So we have another question from the Q&A from Ruth. The first, it's kind of a two-part question. So the first part is, what are some cultural aspects of veterans to keep in mind, or ways they think, or things that they've learned?
They're not to complain. They learn to be very stoic. So in part, when we talk about military culture, you can still hear it to some degree when I talk. When I'm, even though somebody may be your age, I might say, yes, ma'am, yes, sir. And, that's a part of, yes, I grew up in the South, so a part of that is there, but yes, I spent 25 years in the military too. And so those cultural aspects, as subtle as they may be, are there. You can, if you begin to delve into the military culture piece, you will begin to notice people who are veterans long before your other colleagues might. And I can be out to dinner and talking with friends and look over and see someone. I said, that guy was in the military. I said, well, how do you know that? I said, well, his gig line is straight. I said, what are you talking about? What's a gig line? Well, it's when the button side of his shirt is aligned with his belt buckle, aligned with the zipper in his pants, and it goes all the way down. That's a gig line. And so there are those things that this guy's probably been out of the military 20 years. I said the same thing about my brother. Okay, his hair is never more than 1/200th of an inch long. He's been retired for 30 plus years. So some of those things are ingrained within the military, and those are just little physical kinds of feature things. And so never mind the way of thinking. So if you have an officer who comes in, particularly around a mental health issue, they tend not to talk about it because they feel, how can they lead their folks if they're weak? Okay, so they're not going to mention that to you. So then you have someone, they come with that kind of issue. They're not going to speak to you about it either, because who's going to want to be in the quote unquote foxhole with them if they think they're crazy? So you have all of these situations which force you to no tears, no fear, nothing hurts you, man up, take it. All of those things, which again, impact your ability to be healthy, really healthy. And so that's a part of the military culture. Now, we might say we have that same stigma of mental health, regardless of who you are, and that's true, but it is more pronounced in the military sector than it is outside.
I think that's a really good kind of segue into the second part of the question, which was, what advice would you give in approaching them, making them feel safe and comfortable?
Well, again, it depends on, if say you're in a clinic situation and you have a front desk, people come in and they sign up, or they sign in and say they're there for their appointment. So this is what I meant by cultural competency has to run longitudinally through the healthcare system. So that person who is a greeter at the hospital or the clinic needs to understand that too. Hello, how are you, sir, ma'am, whatever. Are you a veteran? Some veterans must say, well, why do you want to know? You say, it's because we'd like to provide you with the best care possible. Okay, so again, that's a training aspect of how to counter if someone feels like, why do you want to know that? Because not all veterans want to reveal that they've served. Take, for instance, those who came back in the Vietnam era where they were spat upon because people objected to the Vietnam War. They were simply doing what they were directed to do. And so you have those kinds of aspects occurring. And so understanding who they are, number one, being able to greet them appropriately, Captain Williams, Sergeant Jones, Command Sergeant Major. All of those things are very, very meaningful. A perfect example is an insurance company called USAA. Okay, it's a one that most military folks belong to and have insurance policies. They could be offered a cheaper insurance policy, but they stick with USAA. Why? Because when you call them up, they say, hello there, Captain Lewis. How are you? How can we help you today? They know that about you. They understand who you are and what you've done and appreciate your service. And so those little things like that cultural awareness of who they are. They don't expect you to know everything about who they are, or if they were a gunny in the Marine Corps, exactly what all of that meant. They don't expect you to know that, but they do expect that you can understand where they're coming from, that they had a rank and what that job was that they did. And if you don't know, you just simply ask them.
So with all of that, I can't believe the time is almost up, really. I want to thank you for your 25 years of service to the military and all of the people who have served for our country, as well as the people who serve our military. I want to thank them for their dedication. I also want to thank our team that we continue to work on, Dr. Vadia, Lawson, Hector, Riscato, and Christina and Bree and Candace and Courtney, all the people who make this possible. I hope a lot of you guys will go back and listen to some of the, we always record these, and hopefully you'll go back and look and listen again to these recorded sessions and look at them, and our journal clubs that really deals with all of these aspects of inequities. I want to thank our young upcoming physicians, Simone as well as Kenneth, for being on here tonight. And I certainly hope that everybody has a very safe and happy holiday. I'm grateful for everybody who's worked on this to make this a very successful program. And it's always great to have alumni come back and be here with us. I know Dr. Lawson had wanted to make a comment, but maybe he can make that in the chat box. Thank you once again, everybody, and looking forward to starting next year with a whole new bunch of sessions. Thank you.
Well, thank you all too for the invite and for taking time out this evening to join me. So thank you again. Happy holidays, everyone.
Happy holiday. So Carl, maybe you can applause.
And Dr. Lewis, thank you very much. I just messaged you within the chat and noted that as a veteran who was a son of a veteran and a grandson of a veteran, I really appreciate you taking on this topic today, and I appreciate the words of wisdom. Thank you.
Thank you.
Great. Well, thank you again, everyone, and looking forward to next year.
All right. All right. Take care, everyone. Be safe. Stay healthy.
Okay.
All right. Good night.